The next session is all about the current treatment of glioblastoma, and we'll cover the current treatment approach, available clinical trials, and the process of enrolling in a study. Our speakers today are Dr. Ankush Bhatia and Dr. Joe Mendez. Dr. Ankush Bhatia is an assistant professor in the Department of Neurology, Medicine, and Human Oncology at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. He specializes in neuro-oncology and helps lead the brain tumor program at the Carbone Cancer Center, an NCI-designated comprehensive cancer center. His clinical practice focuses on the treatment of primary brain tumor and spine tumors. He is board certified in neurology by the American Board of Psychiatry and Neurology, as known as ABPN, and as well as in board certified in neuro-oncology by what we call UCNS, which is United Council for Neurologic Subspecialties. Dr. Joe Mendez is also a neuro-oncologist, but he is at the Huntsman Cancer Institute in Salt Lake City, Utah. He is a clinical trialist who specializes in treatment of primary brain tumors. I have known both Dr. Bhatia and Dr. Mendez to be not only thoughtful and compassionate neuro-oncologists, but also passionate about conducting clinical trials and designing them in glioblastoma to find a better treatment. Please welcome Dr. Bhatia, who will present first, followed by Dr. Mendez.
Hi, Dr. Bhatia. We're going to give you remote control
Great, thank you. Can you
once you
guys
get
hear
the
me
notification.
okay?
We can hear you perfectly.
Great. All right, so, there we go. Okay.
Perfect.
All right. Thanks, everybody. This is a huge, wonderful opportunity, and it's a privilege to speak with you all. Thanks for the kind introduction, Dr. Mamora. So, no disclosures. Today, we're going to talk about reviewing the standard of care for glioblastoma, but really kind of go beyond that to talk about how these treatments are developed. And after that, we're going to talk about navigating the information about alternative treatments, which there's a lot of to talk about, but we're going to try to I'm just going to try to give you like an overview of how to approach that. So many of you may be familiar, but just in case anyone isn't, we're going to review the standard of care treatment for glioblastoma. So first I'll talk about the newly diagnosed setting. And so really our primary goal is always to try to enroll patients on a clinical trial in addition to offering patients the standard of care. There's no better way to advance treatments in glioblastoma than offering patients clinical trials to try to improve the standard of care and prolong survival, but also it's important to balance quality of life. So patients generally present to either their primary care doctor or the emergency room with a neurological symptom such as a seizure or weakness or numbness, and this leads to brain imaging with an MRI, and that MRI will then show a brain tumor. And the most common physician that these patients meet initially is neurosurgery, where they'll undergo a maximal safe resection, which means really trying to remove as much tumor as possible without causing any neurological symptoms or dysfunction. So trying to preserve patients' quality of life but remove as much tumor as possible. After that, patients recover from surgery for a few weeks and meet with their brain tumor team, the radiation oncologist and the neuro-oncologist. About 4 to 6 weeks after finishing their brain surgery, they'll undergo radiation and temozolomide chemotherapy. And this is given for about 3 to 6 weeks, depending on the patient's function. And after that, they get a month break, and then they start adjuvant temozolomide. Basically, adjuvant just means after radiation. We give the same chemotherapy, but at a higher dose for a shorter amount of time for 6 cycles or 6 months, where each cycle, the chemotherapy is given for about 5 days. and the rest of the month is off. This treatment can be combined with tumor treating fields, otherwise known as Optune, which is this device that you can wear on your head and has been shown to be very effective in the treatment of glioblastoma. At recurrence, what happens when the tumor grows back? Well, the truth is, at this point, there's no standard of care, so there's no right answer. Really, it's very important that we have a multidisciplinary discussion. And that's really what that means is the neurosurgeons, the neuro-oncologists, the radiation oncologists, the neuroradiologists, the neuropathologists, we all get together and we talk as a team about what we think is best. And ideally, again, we try to offer patients clinical trials where we can offer them something that has the chance of prolonging survival. But there's also other options, and clinical trials may or may not include surgery, radiation, again, tumor treating fields, Optune, or other medical therapies. Bevacizumab is a commonly used drug that has been FDA approved since it has shown to prolong or to improve quality of life. Although bevacizumab has not been shown definitively to prolong survival. Other chemotherapies that we use at recurrence include lomustine or carmustine. Carmustine is the IV formulation of lomustine, also known as BCNU. Lomustine is also called CCNU. I know there's a lot of names. I'll talk about some of the side effects in a second. And then we could also use various targeted therapies. And so when we do genetic testing of the tumor tissue when the patient has undergone surgery, we look for many genes that we have targeted therapies for. So one example is a BRAF mutation where we might give drugs like dabrafenib or trametinib. Another example is NTRK mutations where we might give entrectinib or larotrectinib. And so those are just a couple examples of possible targeted therapy options. So how did we establish the standard of care? So I've outlined the standard of care treatments, but really the purpose of this talk is to kind of go beyond that and talk about how did we develop these treatments? And so there's been several randomized clinical trials over several decades. So I talked in the past or previously about the importance of clinical trials. And the reason they're important is because that's how we develop these treatments that I'm talking about today. So the first step is maximal safe resection, and there's been multiple retrospective studies that have shown that the more tumor is removed that is removed by the neurosurgeon, the longer patients live. And so we define maximal safe resection in three ways. There's something called a gross total resection, which is where this neurosurgeon has removed all of the disease that's enhancing. And what that means is that when we give gadolinium contrast through the IV, when patients are getting their MRI, the tumor often lights up on the MRI. And if the surgeon can remove all of that lighting up tumor, then that's considered a gross total resection. The next is a subtotal resection, and that's if the surgeon's not able to get all of the enhancing tumor, but there's some residual tumor, but they're able to get majority of it. And sometimes tumors are located in areas of the brain that are very difficult to do a larger section. And so the neurosurgeon might just offer a biopsy where they're able to remove a piece of the tumor so that we're able to get a diagnosis. The standard care is then proceeds to radiation, which I've talked about, and radiation's been around for decades. And going back into the 1970s is when they really started publishing data on radiation as an effective anti-tumor treatment of glioblastoma and other gliomas. So we've been using radiation as a tool for decades, but certainly over the last 30 years, there's been multiple clinical trials studying different types of radiation, whether it be photons or protons, that have really, and we've also been able to discuss how best to outline the treatment fields where the doses should be best given. And so we've really studied this in many different ways to really fine tune the best delivery of radiation. Chemotherapy has been given in glioblastoma for decades, but it really wasn't until 2005 where the first randomized controlled clinical trial was done, where Dr. Roger Stoop showed that the addition of temozolomide to radiation prolonged survival. And then in 2012 and 2017, additional clinical trials were done studying this device that you see here called tumor treating fields. And this is essentially alternating electric fields that are placed on the scalp and deliver alternating electric fields to where the tumor is. These alternating electric fields have been shown to disrupt mitoses and kill cancer cells, essentially. And in 2012, the FDA approved this treatment at recurrence. And then in 2017, it was actually the clinical trial actually showed that it was also beneficial up front. And so tumor treating fields is now a treatment that patients can use in the newly diagnosed glioblastoma setting and in the recurrent setting. And so this is how we established these standard of care treatments. It goes back decades and it involves a lot of research and clinical trials. Equally important to prolonging survival is also preserving quality of life. And so it's important that I touch on some of the side effects of treatment. Radiation, the most common side effect is fatigue, and patients, should expect this to happen, actually. It is a common complaint during radiation and during chemotherapy, and honestly, living with a brain tumor is fatiguing. And so it's an important side effect that we should talk about in terms of how to maximize and treat that fatigue. Chemotherapy, such as temozolomide or lomustine, carmustine, which I mentioned, are chemotherapies that generally are well tolerated. These side effects that are listed here, nausea, constipation, are really easy to treat and prevent with anti-nausea medications and stool softeners um, for the majority of patients. Very rarely, we do see drops in blood counts. We do check blood work very frequently during treatment, but the drops in blood counts are usually mild and don't require transfusions. Bevacizumab, I mentioned, is a IV drug, so it's given through intravenously, unlike temozolomide and lomustine, which is given orally. And bevacizumab really helps with controlling brain swelling, but one of the common side effects can be high blood pressure and very rarely stroke or bleeding in the brain. And this should be closely monitored as the patient's undergoing treatment. Tumor treating fields is the next treatment, and it is a treatment that can cause skin rash. So we closely monitor the skin for toxicity. And targeted therapies are really, the side effects are very drug specific, which may include rash, diarrhea, and joint pains. So how do we manage these symptoms? Seizures are managed with seizure medications can have various side effects that are specific medication. So it's hard for me to go through a long list of those. Cerebral edema, otherwise known as brain swelling, can be managed with dexamethasone. And we try to taper off dexamethasone to treat the brain swelling. Other important considerations are using this multidisciplinary approach that I talked about previously. So this treatment, I'm listing all the treatment teams here, and I'm not going to list them again, but we have a big brain tumor team, and we all try to talk together to best treat the patient. But I think the take-home message here in terms of important considerations is that every glioblastoma is different. Every patient is different. Their genetic profiles are different. And so when we think about treatment, we think about each patient individually because some people are more sensitive than others, and that should be considered while we try to develop a treatment plan. The, sorry, excuse me 1 second here. Ah. So we're going to switch gears now and talk about alternative therapies to the treatment of glioblastoma. So alternative therapies is better referred to as integrative medicine. And so some of the cancer centers where you might be receiving treatment have integrative medicine or integrative oncologists. And these are oncologists who specialize in alternative therapies and have actually, a board certification for these treatments. And so it can get, this is a whole new, another field, honestly, of medicine. And so it's hard to, of course, summarize this in a few minutes, but the general take home is that there's hundreds, thousands of ideas out there of alternative therapies. And so what idea is best? Like, why is it so hard to study these alternative therapies? And so we're going to talk a little bit about
Dr.
that.
Bhatia, we can't hear you.
Oh, sorry. Can you hear me now?
I
Okay, we
can
can hear
hear
you now.
him, Emily.
Oh, okay, good. Um, so the overview to integrative medicine. So some of these complementary therapies are important for managing side effects, minimizing stress, anxiety, depression. But really understand what you're taking and how you're taking it, because various herbs and vitamins and dietary supplements can sometimes interact with chemotherapies, but sometimes they can also help your symptoms like fatigue, muscle strength, endurance, balance. And, I don't want to talk only about integrative medicine as supplements, really just natural things that we all should be doing, like breathing, controlling our breath, exercising, meditating, yoga, acupuncture. All of these things, I think, significantly help patients' quality of life, help with side effect control. So it's really important that you meet with your integrative oncologist and your neuro-oncologist to talk about a personalized care plan. So I'll talk about acupuncture. I really like acupuncture because it's a drug-free option. There's no known, concerning side effects to it. And it's been actually, there's been several randomized clinical trials that have studied acupuncture and have shown that it can improve the side effects of chemotherapy and radiation or following surgery. So the results of many of these studies suggest that acupuncture improves pain, fatigue, insomnia, constipation, nausea, and vomiting. And then we talk about exercise. Actually, this is another very active area of research. And I'm a big believer in how exercise, patients who exercise, patients who are better fit, um, have better control of their health and their medical problems, often live longer and do better, have better fatigue and mobility. So I don't want to, I want to draw importance to that. And then herbs, botanical, and other products, this is a long, long, long list. I wouldn't be able to go through it all today, but it's important that you understand what's helpful and what could be harmful. So I really encourage you not to do this alone. I really encourage you to consult with your treating team. There's also a lot of cancer centers have chemopharmacists that specialize in brain tumors or specialize in these alternative therapies. And will a substance work as the label says it will? One of the issues with alternative therapies is that the FDA doesn't regulate exactly what's in each supplement. So something simple like melatonin, might have different variations on the shelf with different dosages and different chemicals inside of it. And so not everyone's substance, what that you're buying off the shelf may have the same um, makeup. So really think about whether it's worth the cost and really talk with your team about whether it interacts with your treatment. What are other considerations for herbs and dietary supplements? So I just mentioned this, that the United States Food and Drug Administration, the FDA, they don't really evaluate safety and labeling of dietary supplements before they're sold. Because these aren't drugs that you need a prescription for, there's a lot of variation in what they're made of. The clinical effects of these products are often difficult to predict due to a lack of human data. So you can imagine why it's hard to study these alternative therapies, because if they're not regulated by the FDA and the doses vary, it's very difficult to study in a clinical trial how we should be dosing this alternative therapy. Um, the potencies of herbal supplements are influenced by plants or plant parts used, harvesting and processing methods, and the amounts of active compounds absorbed, sorry. So again, talk with your doctor. Okay, so dietary supplements for cancer prevention. So I get into a little bit of the science here, not to get too deep into it, but what are free radicals? Do they cause GBM? Well, the truth is there's no proven way that we know to prevent glioblastoma. But free radicals are chemicals that have unpaired electrons, and they're present in the environment, and they're present in all of our bodies through normal metabolism. But they can interact with DNA and contribute to cancer like glioblastoma. So antioxidants is a very common dietary supplement that a lot of people, think is very good for you. And so these are substances that inhibit the process of oxidation associated with free radicals. They're found in many foods and dietary supplements. Specifically, vitamin C has a lot of antioxidant effects. But unfortunately, there's really no conclusive evidence that antioxidants reduce the incidence of glioblastoma. And actually, if you take too much vitamin C, there's thought with a lot of radiation oncologists that it can be harmful to the radiation that is being received, in that it can reverse the effectiveness of radiation. And so it's, again, important to discuss whether your radiation oncologist or your neuro-oncologist is okay with the current treatment that you're on and in taking antioxidants. Similarly, daily multivitamins is a question I get a lot, and really studies have kind of yielded mixed results. We don't know that they have little or any effect in reducing the overall risk of glioblastoma. Dietary supplements during glioblastoma treatment. So are there any herbs that can be used to treat cancer? Many cancer treatments are derived from plants and are developed after rigorous clinical trials for safety and efficacy. Turmeric, medicinal mushrooms have been well tested, but lab studies don't always translate this to human studies. So again, the dosages are difficult to know for sure, what we should be using. Most herbs and dietary supplements have not been studied together with chemotherapy drugs. So again, we don't always, even if we, we're okay with a dietary supplement, it doesn't mean that we know how it's going to interact with chemotherapy. So a lot of oncologists do take the side that patients should avoid these products during chemotherapy out of an abundance of caution and safety. But I would encourage you to just be honest about your goals and intentions. I think that a lot of providers are very understanding, and try to help you in the best way that they can. So let's talk about some of these take-home points. So today we talked about the standard treatment for glioblastoma, which, as I outlined, is maximal safe resection in combination with radiation and chemotherapy called temozolomide, in combination with tumor treating fields or Optune. At recurrence, there's really no standard of care. So there are chemotherapies that we discuss, such as lomustine, carmustine, bevacizumab. These are chemotherapies that can be used at the time of recurrence. But ideally, if there's an opportunity to enroll in a clinical trial, I would encourage that. And these treatments are only here because of the hard work that we've done through clinical trials. And so it's important to develop an individualized treatment approach. Is a clinical trial right for you? And Dr. Mendez is going to talk about that next. Understand that every glioblastoma is different. And I can't emphasize this enough. When patients go on Google, they see what survival might be like in glioblastoma. But the truth is that because every glioblastoma is different, and because every genetic profile is different for every glioblastoma, it's very difficult to prognosticate or understand how patients are going to do. And so I think that understanding that every person is different is key to approaching this disease. And then lastly, it's always our goal, to balance being aggressive and maintaining quality of life. I think that's it. And then, yeah. Thank you so much.
Thank you so much, Dr. Bhatia. We welcome Dr. Mendez, who will be sharing the second half of the presentation, and we're going to give you remote control of the slides now. All right, you should have control. Click the screen twice. Perfect.
Hey, good morning, everyone. Really feel like this is a great opportunity. So thank you so much for letting me chat with everyone who's attending. So what I'd like to chat about today is the clinical trial landscape. The goal, I hope, today is that you leave with a little bit better understanding of the world of clinical trials. And so my hope is to walk you through this process, so that if at this point, at some point in your cancer journey, clinical trials become an option, you feel a little bit more empowered to consider these and have some fund of knowledge that can help guide you in decision making. So in general, what is a clinical trial? I'm pretty blunt with patients and just let them know that these truly are experiments that we're performing on humans. And in our case, obviously, our patients. And the idea is to understand if an intervention that we're looking into is safe, but also not only safe, but in addition, effective. And when I say intervention, really most of the time in clinical trials, we're speaking about drugs, i.e. therapies to try to help fight cancer, or potentially devices that may also be able to help us fight cancer. So when we chat a little bit about clinical trials, I think there is really kind of some important things to understand. When we do create clinical trials, oftentimes what we are doing in the case of glioblastoma is building on something that's already established in the literature. So a good example would be that oftentimes in a newly diagnosed patients with glioblastoma, we're adding to the standard of care that is already in place. On occasion, we may remove a drug that we've shown not to be potentially efficacious, but in general, most commonly we're adding. In the setting of recurrent glioblastoma, we're looking and exploring for something to be better than what is already in place. And so oftentimes we will replace what is considered common use in recurrent glioblastoma. So in regards to treatments in glioblastoma, I find it always helpful to kind of give an overview of what I call the buckets of how we treat cancer. And this is a general slide. What I mean is that this does apply to a lot of other cancers. But specifically, I wanted, of course, to reference these in relation to glioblastoma. So when we talk about traditional chemotherapies, we're often talking about these treatments that are very nonspecific. The goal is that they're going to kill cancer by disrupting their ability to divide, i.e. spread or grow. And by not being specific to a specific cancer type, these actually are well known, and as they're displayed in movies and on TV shows, to be quite toxic. And the reason for that is because they're attacking any cells that rapidly divide. And those most common ones are often in our gastrointestinal tract. And so that's why nausea and vomiting are pretty common in traditional chemotherapies. An example of this in glioblastoma treatment would be chemotherapies like Temodar or temozolomide or CCNU lomustine. The second bucket is targeted therapies. This is what you may have heard and may hear in the news described as personalized medicine. And these are treatments that kill cancer by attacking a unique pathway that allow the cancer to grow. And sometimes we'll use the phrase like an oncogenic driver, the idea being that a change in the tumor that causes it to behave like a cancer. And these are unique drugs and specific to a certain type of mutation in a patient's tumor, hence the name personalized medicine. Examples of these drugs are, for example, there are some drugs that target, for example, an FGFR mutation or a NTRK fusion. These are drugs that we've also explored in glioblastoma as well. The third bucket is immunotherapies. These are treatments that are designed to try to get your own immune system to attack cancer. And these therapies, kind of the way that I describe it to patients, is that oftentimes an individual's cancer can do a really good job of escaping our immune system, in a sense, hiding in plain sight. And so these therapies are designed to, in a sense, take the mask off of the cancer so that your own immune system can help you fight the cancer. The key point of this is really that each of these buckets, so to speak, have different ways or mechanisms of treating cancer. And with each of these, they have their own potential side effects. And they all can be, unfortunately, very toxic, but usually have a very unique profile of their toxicities related to them. These are the three buckets that we pull from when we design clinical trials for patients with glioblastoma. So clinical trials, key things, they help us understand side effects and toxicity, what we reference as whether or not they are safe. In addition to that, the goal of a clinical trial is to help us prove if they're effective for patients. Do they help patients live longer? They provide a therapy that might not otherwise be available. And of course, the goal of introducing that is because there's some basic science that would suggest why it could help a patient with a glioblastoma. And it also creates the potential for finding or discovering a therapy that improves outcomes for patients, which I mentioned, and which we refer to as prognosis. So the key things to know about a clinical trial is how I describe it to patients is I like to think of the options as a continuum. On one end of it you could win the lottery and basically receive the next best therapy that is FDA approved. The idea being that it's very effective, but hopefully has low side effect profiles, meaning toxicity. And then unfortunately, there's the opposite side of the spectrum where patients can undergo a trial but not have any benefit from the trial, but also have a bunch of side effects. And along this continuum is oftentimes where patients lie when they do participate in a clinical trial. However, we don't know what actually the experience is going to be for each patient because, again, it is an experience. And literally, you as the patient are trying to show us and answer the questions that I posed in the last slide. Another key part of clinical trials is completely voluntary. It's really important to remember this. You are giving us the ability to try a drug. And of course, we want to make sure you maintain autonomy. And so at any point, the trial doesn't feel like the right thing for you or the toxicities are too much, we can always remove or take away or get rid of the clinical trial and try another treatment that feels more appropriate for your goals. You can stop participating at any time as well. So for example, if you do end up starting a trial, you can stop at any point that you would like. And so it's really, really important for patients to understand that once they sign up, they're not committed in any way. And then most importantly, there is no guarantee that you'll benefit from the clinical trial. Of course, our hope is, and I think that's a pretty big keyword in my opinion. When I think about clinical trials, I really think about that. For me, it really equates to hope. This idea and this, a goal of getting a better treatment for patients with glioblastoma. So really, when you're doing or considering a clinical trial, there are two time points at which a patient can enter a trial. One is at the time of their diagnosis. So when they received the unfortunate diagnosis of a glioblastoma, patients following surgery will then enter a clinical trial potentially. And the second time is at recurrence. And recurrence is a general term in the sense of when the tumor comes back. But what I mean by this is that any time the tumor comes back, whether it's the first or second, you can be eligible to consider a trial at those time points. So important to keep in mind. And then what do I need to know about a clinical trial? So we're going to dive into kind of dissecting trials a little bit more in depth. And so when we design trials, the trials are specific to a specific type of diagnosis or tumor type. And in the case of today's talk, we're talking about glioblastomas. And then again, as I just mentioned, the time point in your treatment. So at the time of being diagnosed versus recurrence, you will find some trials that do enroll into both, meaning at the time of diagnosis and also at recurrence, you could enter a specific trial at either of those time points. In addition, there are some trials that are going to dictate or require that you have a specific mutation or alteration in your tumor in order to participate. And in those cases, we're referencing that bucket that I referred to earlier of targeted therapies or personalized medicine. And the reason why that's required is because the drug is typically designed to attack that specific mutation or alteration. So if you don't have it, you're unlikely to get any clinical benefit from it. And in those cases, that's why we want to prove that that alteration is there. Okay, the other key part is you need to meet all eligibility criteria. So the way that I describe it to my patients is there's literally a sheet with check marks. It's very objective, and patients must meet all of those criteria, and they're very specific, which is really, really important. And the reason for that is because we want to ensure safety. But we also want to ensure that the data that we collect from patients is sound and scientifically sound so that we can find results that are truly applicable and also generalizable to the general population. So good examples of these would be the number of prior treatments you've had can dictate whether or not you can or cannot enter a trial. You do need to be what we refer to as healthy, in quotations, enough, and we use a scale called typically the Karnofsky scoring scale. There are often limits to how much dexamethasone you can be on the trial. You typically have to have what we refer to as measurable disease on the brain MRI. And when I say measurable disease, I'm referring to the brain MRI scans that use contrast. So that bright white that appears on the imaging. And then, as I mentioned earlier, there could be specific alterations in your tumor that need to be present in order to participate. When you take a broad look at the design of a trial, one of the things that you'll also be introduced when you learn about a trial is what phase it is in. I like to think about the phase of a trial as, in a sense, how early is it being introduced to a human? And there are pros and cons to each of these phases. So if we look at a phase 1 trial, these are trials that are typically looking to understand the side effects of the drug on a human. And then we're also looking to find the correct dose, i.e. the dose that gets to where we want it to get and also is tolerated. Phase 1 studies can often include a surgery as a part of the clinical trial. In addition, the number of patients that enroll are low, meaning there's not as many patients, for example, as a phase 2 or 3. Patients are not randomized in a phase 1. So most patients do really like phase 1 studies because you know you're going to get the drug that you're interested in trying, i.e. the investigational drug. And there's typically never a placebo in a phase 1 study. The other nice thing about a phase 1 study is that these trials, as far as their eligibility criteria, are pretty loose, meaning the goal is to try to get patients to be able to test the drug on, so to speak. In phase 2, when a trial moves to a phase 2, there usually is already some data about the drug. And the goal of the phase 2 is to understand if there is a response, meaning is the drug helping people? Is there some efficacy to it? We're also trying to narrow down and gather more data about side effects as well. And as you can see, there's more number of participants in a phase 2. Randomization can occur in a phase 2, but most commonly in a phase 2, you're going to have a randomization where you're actually going to know what drug you're getting in that clinical trial. There's typically not a placebo in phase 2s. And I would say in general, phase 2s are probably the most common phase of clinical trials that you'll most likely see when you speak with your providers. Phase 3s, this is kind of the next step towards FDA approval. So a phase 3 is a very large study, typically done in multiple institutions. And the idea is to confirm some initial signal of efficacy, benefit to patients. And in an ideal world, the phase 3 will have a placebo, and it will be what we call double-blinded, which means that no one will know what they're getting. And the reason why this can feel unethical to individuals, and the reason why this is the way we prove with the least amount of bias. So from a statistical perspective, that the data is actually correct and true. Now, what are some practical considerations if you're a patient and want to consider a trial? Really, the key thing I stress to my patients is that we want them to understand that this is a huge time commitment. And again, the reason for saying this is not to deter patients from participating. It's just to make sure they're informed and to make sure that they're aware of what they're getting into. I think knowledge is really, really power. So in general, on clinical trial, really, you typically have more frequent visits. The visits in clinic are longer typically. You may have more frequent lab draws. Oftentimes, clinical trials will include questionnaires as well. And oftentimes part of the treatment may include an observation period to make sure you don't have a reaction to the treatment. And then sometimes you may have a long day of assessments. So for example, blood draws that may last for several hours throughout the day. The reason for all of this is, one, data that we need to gain to learn more about the drugs. But in addition, all of these things are set in place to help keep you safe as the patient. Some other practical considerations. You are limited in what you can do while you're on a clinical trial. So in general, you should not be starting any drugs or supplements unless you're running them by your team. And the reason for that is because in case one of the supplements you take is theoretically efficacious, but we don't know yet, then it would make it difficult for us to differentiate between your supplement and the investigational drug being the true thing that helps patients. There's also a lack of flexibility in a clinical trial. A part of the clinical trial is that everything is very much dictated in a time-oriented way. And again, this is to ensure safety for patients. And so this can be a little bit tough sometimes for patients where flexibility may be more helpful in their day-to-day life. Cost is another variable. So in general, when we think about clinical trials, almost everything that you do in a clinical trial is typically going to be considered what we would call standard of care, i.e. we would get these labs and things regardless of the treatment type we gave you. So they will be billed to your insurance. And then there's another segment, particularly and primarily only the treatment itself, meaning the investigational agent that is given to you for free. Yeah, free is probably not a fair word to use because you are volunteering your body and potentially undergoing side effects. But the point being is that part is typically not billed to you. So what are some perks to providing a clinical trial? Personally speaking, and again, this is my opinion, but I agree with Dr. Bhatia, really, in my opinion, clinical trials are the most appropriate way to treat patients. It's the only way we change the current prognosis of glioblastoma. And so I do encourage patients to participate. And unfortunately, as the numbers suggest, our treatments are not the best at this time, unfortunately. So the benefits to a clinical trial are that these are typically going to be run by a specialized center institution, along with a very highly specialized physician, typically a neuro-oncologist. So that allows you to get very dedicated, very specialized treatment. And this physician is usually a physician that's only treating brain tumors, as opposed to, for example, oncologists who may treat multiple types of tumors or, cancers. You usually will have closer observation with more visits. So oftentimes patients will feel, in a sense, more protected or more cared for when they're on a trial because of the amount of time they spend with us. In addition, your care will be multidisciplinary. In general, when we're doing a clinical trial, there are multiple people who are playing a role in that. Everything from potentially a pharmacist to the neuro-oncologists themselves, to the radiation doctors, to the radiologist, and then also, of course, the surgeons. In addition, when you participate in a trial that is altruistic, everything or the things that you do when you participate in a trial are helping us understand about these therapies. And as a result, they do help other patients with glioblastoma work towards getting a better treatment in place. And then most importantly, our hope is that the clinical trial that you participate is actually the next therapy that's FDA approved, and you receive it because you participated in the trial earlier than other individuals. So how do I find a clinical trial? Key thing that I would recommend is if you have a neuro-oncologist, I would chat with them and discuss your options. In addition, earlier you guys heard that the ABTA's clinical trial finder. So that's another great resource for you to explore. There's also the Brain Tumor Network. And then, of course, the clinicaltrials.gov website. And the clinicaltrials.gov website can be a little bit challenging to navigate. So oftentimes, I will help patients navigate that in clinic by pulling up the website and kind of showing them how to navigate kind of the basics of exploring clinical trials in glioblastoma. And then there's also WE trials as well. So these will be available to you at a later time to explore. This is just a screenshot of the two that I mentioned, the ABTA and then also clinicaltrials.gov. So are clinical trials an option for me? Of course, but really the question is does this make sense for your care and your goals? So things to consider. These are kind of just a list of things. Do you feel compelled to contribute to the science and hoping to help other patients or yourself? Probably the thing that I focus on most for patients is understanding the prognosis and the reality that your time may be limited. Do you want to spend potentially more time in the hospital setting participating in a clinical trial? Because of course, this would mean you taking time away from your loved ones or other things or activities or hobbies that you might enjoy and that bring you enjoyment. There's a whole list of these though, but just things to think about as you're contemplating whether or not this is a right thing for you as a patient. And again, as I mentioned, or have alluded to, if you're lucky, lucky is probably not the right word either, but the point I'm getting at is if you're interested in a clinical trial, some institutions will have multiple trials that they may be able to offer you. And a common question that I'll get from patients is, which is the right trial for me? And unfortunately, that is an impossible question to ask. If you recall, the goal or the idea of a clinical trial at itself is an experiment. And so your participation in the trial is actually how we answer this question. And so it's not a question we'd be able to answer in clinic. And so often what I'll do when I get a question like this from a patient is I'll tell them, I think that the two primary things that really kind of sway a patient's decision is one, do they come in with some sort of idea of what they want? For example, some patients are really excited about immunotherapy, and then maybe that's how we choose a trial because they have an interest in immunotherapy. But more commonly, what I would say is that potential side effects of a clinical trial drug may help you decide what trial to participate in. Maybe there's a toxicity that you're not willing or not interested in experiencing, regardless of the statistics or how frequent it is. And then in addition, some trials are very, very, very time intensive. And so sometimes that can help patients in making decisions, whether it's coming in the clinic once a month or coming in clinic once a week, or even getting treatments multiple times in 1 week. And so those are kind of, in my opinion, the practical matters that really help patients guide treatment or choosing between clinical trials. All right. Another question is, do I travel for a clinical trial? So it's a possibility that your institution may not have clinical trials available to you as the patient, or the trials that are available you may not be eligible for. That's where those finders come into play and to try to help you. I would say that clinical trials, traveling for a trial is definitely an option for patients, but it really comes down to a personal decision. And in my experience, it is very challenging for patients. And this is an unfortunate reality. At the current time, obviously, this would be potentially a financial burden to potentially some patients. There are trials that do have reimbursements available to help patients with assistance to getting to travel, whether it be airfare, whether it be mileage for reimbursement or hotels, things like that. Other key things are just, what does the rest of your life look like? You might find it challenging to travel every couple of weeks to another city if, for example, you are also working, or you have a family that you're caring for, or you have limited support to help you navigate getting to the airport, flying on a plane, those kind of aspects. But definitely not trying in any way to discourage this, just understanding and want patients to understand and be prepared for the possibility of some additional challenges that they might face in this setting. All right, so how do you make it feasible if you're going to travel? And here, really, what I encourage patients to do, and I have my social work team help patients as well, but trying to outline all the resources that are available to patients so that they can hopefully achieve this goal of traveling for a clinical trial. So often things that may be available, there's a possibility of housing options for patients. So for example, at my institution, we have the Hope Lodge, which allows patients to stay. And then in addition to that, we can look at transportation options, things like Angel Flight, and then of course, monetary assistance. And this can be in the form of grants, for example, to help patients be able to get treatments. So do I have to participate in a clinical trial? And the answer here hopefully is clear, but it's no, of course. And the key things, once again, is we want you to understand that if you do participate, it's completely voluntary. This is a choice that you get to make as the patient. And in my opinion, some patients are asking, what's the right choice, meaning doing a clinical trial or not doing a clinical trial? And in my opinion, the right choice is whatever choice feels the most appropriate for you and your goals. And then again, as I already mentioned, even if you do decide you want to, you can always stop at any time. You should never be pressured to participate in a trial. And it does not negatively impact, in my opinion, your relationship with your physician. I tell patients this has no sway on how I think about them as a patient. Most importantly, my job is to be there and support them in this journey. And most importantly, inform them of all the options that are available to them. And clinical trials are an option that's available to them, but may not be the right thing for them at that time in their cancer journey, or may never be a part of that journey. And that concludes my chat.
Thank you so much, Dr. Mendez, for sharing with us the second part of that presentation. We welcome back Dr. Bhatia to join us for Q&A. We have a significant amount of questions that have come through. Feel free for those of you who have not entered in your questions to do so now in the Q&A button at the bottom of the control panel. All right, we're going to get started here. Dr. Bhatia, feel free to join. There you are. Okay, and Dr. Umamura, thank you so much. All right. Okay, so we have a few questions specifically on the use of Optune or tumor treating fields. And I'm going to just combine this. There's like 3 questions in one. So one is asking about median survival rate. Does Optune help prevent recurrences? And then should someone continue the use of Optune while experiencing a recurrence?
Ankush, do you want to take that one since it's
Uh,
about the treatment?
Sure. So tumor treating fields has been shown to prolong survival by a median of 5 months. So that's about average. So some people do better and some people do worse. The way we studied it, it was versus someone not wearing the device. It's hard to know if we use it as, it sounds like one of the questions was a preventive use of it. I think that's kind of the intention, right? To like delay the recurrence of the brain tumor. So I would say, yes, it's used for people that are being treated on observation. If they haven't recurred yet, they're encouraged to continue using it. In terms of a cost-benefit analysis, certainly, hopefully, your insurance covers it. I know they have assistance programs for those who don't. Compliance is another issue for sure. I would say that as long as it's not impacting your quality of life, I think it's a good treatment to consider. Was there another part of the question that I missed?
The part about if someone should continue the use of Optune while experiencing a recurrence.
Yeah, that's a tough one. I think it's a personal call because it hasn't really been studied yet in that way, to my knowledge. So we studied it in the newly diagnosed setting, and then we studied it in the recurrent setting. We studied it in 2 different ways. We didn't necessarily study it in that situation, though, one could argue that it might be helping delay recurrence, even though the tumor's already recurred. but I think it's a personal decision between, your doctor, in terms of how it's benefiting your quality of life, how it's, how you're experiencing the side effects from the treatment or not.
Yeah, I agree with you. I would say that, just to clarify for people listening, when we say it was tested in recurrent setting, but it's not tested in that way, it was started at the time of recurrence, not so much continued on at the time of recurrence, right? So we don't really have a data to say, if you continue, if there's benefit. Oftentimes, I think the thing that we tend to say, what I tend to say is, well, it may be slowing things down, but it certainly wasn't good enough at a certain point once there is a recurrence. And just as we would drop other chemotherapy when it's not good enough, because it certainly isn't toxicity free. People do get sores on the head or cumbersomeness, or sometimes we live in Arizona, and or even when I lived in Michigan, people can get really hot and it can spark. So it's not risk free necessarily. It's low risk compared to drug. So I agree with Dr. Bhatia. It is personal decision. If they really want to continue and insurance coverage continues, I don't necessarily say you have to stop, but I think it's a personalized conversation. Dr. Mendez, do you have anything to add?
Yeah, I think it's just important to remember most clinical trials for recurrence are not going to allow you to use the Optune device. So that's something to really keep in mind. If we look at the data in newly diagnosed glioblastoma and the use of Optune, if you kind of pick apart the clinical trial, patients actually use the device through up until the second recurrence. And so it is harder for us to extrapolate that data and understand how to apply it specifically in the question being posed. But I think in the context of clinical trials, this typically will not be an option for you. You would be required to stop the use as you enter a clinical trial for testing a new investigational therapy.
Thank you.
Thank you all so much. All right, next question we have here is, can you explain why there are only two entry points for clinical trials, that being newly diagnosed or recurrence? And why can't someone enter a trial when, let's say, they're in active surveillance?
Yeah, that's a really good question. And I think probably the best way to think about that is really kind of from a statistics standpoint or a response assessment. So from an FDA perspective, what we have to do as clinical trialists is prove that the treatment is safe, but also effective. And we do that primarily radiographically. So what I mean by that is we use the images, the brain MRIs, to help us understand if a patient's tumor is stable, growing, or even regressing, getting smaller. And that's why we use those specific time points as kind of a resetting of the clock, so to speak. So for example, if we were to allow a patient to enter when their tumor is well controlled, and then let's say a year later the tumor recurred, it would be difficult for us to understand if that was the tumor of the investigational drug, or if that was just the natural history of their glioblastoma. And so at that point, we want a key time point at which there's a change in the tumor's behavior as an indicator to start a new treatment. And then we want to follow that until it recurs again, because that'll help us understand the duration of control of the tumor. In general, clinical trials are going to look at two primary endpoints. That's the goal of the study, meaning what is the thing they're looking for? One is going to be the time at which you start a treatment to the time which the tumor grows. And then the second can be overall survival. Most glioblastoma trials, the goal is to understand overall survival. So the time of diagnosis until the time of death. But we do also care about that progression-free survival, which is that time of the intervention to the time of growth of the tumor.
I think that was really, insightful for talking about how the statistical endpoints are designed. I will also add, from an ethical standpoint, we have to be mindful when we're designing clinical trials that, we are talking about vulnerable population with patients with glioblastoma, and that we are testing these treatments specifically or devices, in an ethical way, in meaning if someone may not need a treatment at a certain point, we don't want to put them at higher risk, or so there are some trials that may allow entry, like when you're being observed, depending on what it's testing. But most of the trials, the common entry point is newly diagnosed because everyone needs treatment at that point. You can compare to what they're going to do standard of care. Those are common ways to test. And recurrence also because that is the time that you need something. In other cancers, and for example, in lower grade gliomas, there are some studies that are testing during the maintenance or observation because there are drugs where we think it might be beneficial to extend the time of being watched. If we had a treatment approach such as that in glioblastoma to test, there may be a trial to enter, but those are not that common, especially in US. We have seen some smaller studies looking at different safety endpoints. With different entry point in other countries, but that's why that's the common entry point.
Thank you. I want to get to some of these other ones, but if we can answer this next one very briefly, is why do most trials requires people to be less than the age of 70?
Most of the trials that I'm familiar with don't have an age limit. It's usually a functional status limit, meaning how functional are you as an individual in order to participate. So that one is typically not something that I see in the trials that I run, for example, at my institution. We usually don't ever have an age cap, so to speak.
Great, thank you. All right, moving right along. Can you explain the use of gliadel wafers and gamma tiles or drugs being administered directly to the tumor site?
I can comment on glial wafers. So it was a treatment that showed a survival benefit. The data's some pretty old now, but there was a lot of, unfortunately, there was a lot of like infections and some issues with toxicity. And so the survival benefit with glial wafers, just so that everyone knows, that's like something that you can insert into the brain during surgery. It's like a chemo pill, basically, or a wafer that's inserted into the resection cavity. But because of that, because we can deliver the same chemotherapy orally and there's less toxicity and side effects, it's preferred to do that orally instead of through surgical implantation. That being said, and also it's kind of not, in my opinion, utilized that frequently anymore, glial wafers. And it can exclude you actually from some clinical trials as well. What were the other questions?
The use of gamma tiles. Yeah, the use of gamma tiles.
I'll let someone else take that one. I don't do a ton of gamma tile.
I can take that one. So the gamma tile is essentially a tiles that emit certain type of radiation. So sometimes we call that brachytherapy, which in some cancer it is used, like bladder cancer, for example. The idea is, after surgery to let the wound heal, a lot of people do not receive treatment like chemotherapy or radiation. So the idea is, what can you do in the meantime? Similar ideas glial wafer, bridging that gap. With that said, its approval for use is not, these devices, they don't have to they don't have to have same kind of evidence as drug treatment in showing improvement in efficacy to be approved. Most devices do get approved, can be approved with just safety use and the feasibility use. So you have to be mindful of that. And what takes into consideration of efficacy is if it makes it into guideline. Those things do. So for example, Dr. Bhatia is part of the National Cancer Network's guideline committee. And when these committee members sit down and talk about what treatment should be part of the guideline, not only do they look at the FDA approval, they also look at what is the evidence for efficacy in certain population. The gliadel wafer and gamma tiles are not necessarily in the forefront of treatment because it has not really shown a robust evidence in efficacy. But it does get used in different time points. And I think if that is the appropriate treatment or not, you should discuss with all of your team, not just one person.
Yeah, I think just one last thing. I think it's important to understand too, again, often this will exclude you from clinical trials, the use of these devices. And then the other part too is the imaging becomes very difficult in both of these techniques to interpret. And so in that way, it can be make it very challenging on your team to understand if your tumor is growing or if it's stable. And actually what they're seeing is actually just related to the tile or the wafer itself. So it does complicate interpreting the imaging, just to keep in mind.
Thank you so much. All right, next question is, we have a couple questions about alternative therapies or supplements contributing to long-term survival. What are your thoughts on this? I know it could be controversial.
Yeah, I mean, I think there's, like I said, I think there's some interesting alternative therapies, and I think if as long as they're safe, they don't interact with the treatment plan, they don't exclude the patient from future trials or studies, then I think it's reasonable to try. You know, I always try to do it in a multidisciplinary way, but we don't have necessarily an alternative therapy that we know that has entered standard of care that has been proven to prolong life. That being said, you know, we do have there are clinical trials out there that are studying, like for example, the ketogenic diet. I think I saw something in the comments about a question about that, and so that is an ongoing randomized clinical trial that's a patient can enroll in right now, where they're randomizing patients to ketogenic diet versus not. And you know, so we're going to study these things one step at a time. But I think there's thousands of alternative therapies, so obviously, and there requires a lot of money to study these clinical trials, to do these clinical trials. So hopefully with time we'll get the answers.
Any other thoughts? All right. Oh, go ahead, Dr. Mendez. Were you going to respond to anything?
Yeah, the phrase that I'll use with patients is, as Dr. Bhatia pointed out, what I really want to know is if you're using them so that I can help understand if they're contributing to side effects or toxicities that you may be experiencing as a patient. And really, when I talk to patients, it's not that I don't discourage the use of them. Really, my practice is based on what I refer to as evidence-based medicine. And so in that context, what I tell patients is the reason why I don't recommend supplements is not because I don't think they're effective. It's just because I don't have the data to tell me that. So it's possible they could help. It's all possible they could hurt you, but I can't tell you that information. So I typically don't recommend that. And that's really kind of the basis. And that's exactly why we don't use them in clinical trials, is because if they're efficacious, they will give us a false sense of hope of the investigational drug. Or if they also cause toxicity, they're going to tell us the drug is way more toxic than it might otherwise be if you weren't on those supplements.
Great, thank you. All right, next question here is temozolomide only useful for some types of glioblastomas?
Yeah, that's a good question. So when the clinical trial that showed that temozolomide prolonged survival was published in 2005, at the same time there was another article that showed something called MGMT, and how MGMT is a marker that if it's positive or present in the tumor tissue, that it's driving kind of the benefit from temozolomide, and that patients who have MGMT methylation, or you could call it positive, they are the population that's more likely to benefit from temozolomide. So there are clinical trials that therefore use MGMT as a stratification factor. In other words, like they say, well, if you're, or in their eligibility criteria, excuse me, where if you're not MGMT methylated or positive, then the temozolomide is less likely to work. So let's try to replace it with another investigational or experimental agent that might work better or prolong survival of glioblastoma.
I would just note, I think that was an excellent answer. And I think to add to that, less likely is the key word, not likely or unlikely or will not work. So, the thing we run into is when we do supplement with interchange the temozolomide to another drug, we want to make sure we're not doing that on methylated people because that would be quite problematic. But when patients get randomized to the standard of care, oftentimes it can be discouraging because they feel that they were just giving a chemotherapy we won't work. That's not the case. It's just less likely than methylated people. And then the trial did show a difference even in unmethylated people.
Yeah, and I guess I'll also add to say that I've seen this assay, this test that we use to test for MGMT. I've seen various results as well. So like the test isn't perfect, right? So the test tells you that your no test is perfect, right? So the test tells you that you're MGMT negative. you might have a degree of positivity that didn't meet the threshold to call it positive, but so what do we do with that, right? So we still offer temozolomide to all patients because there's still a possibility of benefit.
Great, thank you. All right, we have time for one more question. So we sometimes hear about treatments that are approved in other countries and patients feeling the draw to possibly go to another country to receive treatment. Can you explain why some of them are approved, some treatments are approved in other countries, but not in the US?
Dr. Mendez, do you want to take that?
Yeah, I think it's important to understand that well, maybe not each, but a lot of countries have their own regulatory standards. So the FDA is ours, and each regulatory government body is going to have different criteria that they may declare as needed in order to approve a drug. And so I've worked with several clinical trials that have gone on not only within North America, but have also been global in many other countries. And each of the countries typically will have a similar process. For example, of submitting a drug for new drug application, but to the governing agency within that country to get approval. And so it's hard for me to comment on exactly why a drug in Europe may be approved but not approved here. But that would be the basis of that. In addition, there are a lot of clinical trials that we perform in the US, but we don't perform in other countries. And the same in other countries where they may be running a trial there and not performing it in the US. And so we don't have that data or that experience here. And what we do see though is sometimes there is a drug approved in another country. And then the company may, for example, the pharmaceutical company may have an interest in exploring it in the US and then trying to get approval through the FDA so that individuals in the US can also have that drug available to them in their home country.
Yeah, and I would say if something is very, very promising, it's very unlikely for the company to not explore the US market because it is a large market.
Yeah, I think that's a really good point, Omar. I think that another key thing for patients to think about is, unfortunately, a lot of our society is driven financially. And so if a pharmaceutical company has a good drug, they're going to pursue its approval in all countries because that just equals money and gaining. And all of these clinical trials are very, very expensive to run, which is why most of them you will see oftentimes are supported by a pharmaceutical company who is usually the owner of the investigational agent. The nice part is we also, as physicians, participate in these more cooperative groups where we have multiple experienced and also very specialized individuals creating clinical trials and using foundations and grants to try to help patients at a low cost. And so those are other kind of the approaches that we take to try to get these trials off the ground. And to you as a patient.
Thank you. Any final last comments about anything that was covered today?
No, I think it was I'm so glad to see the questions really touched upon the two bucket, we wanted to make it into kind of what we already do and how we investigate. And I hope this sheds some light in how the physicians are thinking about these trials. We are not trying to be exclusive and keep people out, but we do have to put guardrails so we can actually answer those questions.
Thank you so much. Well, thank you so much. Oh, Dr. Bhatia, were you going to say something? Go ahead.
Oh, no, I was going to say thanks so much. I thought the questions were excellent.
Yes, thank you.
Of
Yeah,
course.
and
Thank you.
thank you so much for Doctors Baji and Mendez for taking time on Saturday to talk to us.
Yes, we really appreciate you both just presenting this excellent presentation. There was some feedback in the comments of, I believe, from some of your patients saying that they're under your care and they really are grateful for both of you. So thanks for spending your morning with us. If you have any free time, I know both of you are busy. If you have a few moments, if there are any unaddressed questions that you feel strongly to respond to, you are welcome to. But thank you so much for being with us this morning.